Identifying and treating pain in residents with dementia. The Alzheimer's Disease International World Alzheimer's Report 2010 reported that Alzheimer's dementia population of 36 million would exceed an alarming 115 million people across the world by year 2050. Research also indicates that in the last year of life, pain management for Alzheimer's patients is the most undertreated end-of-life condition, especially in the last few weeks or months, due to decreasing cognitive responses and abilities. Additionally, residents with dementia that spend their final days in care facilities are estimated at 75%, to which the total widespread presence of pain was found to be from 50 to 80%. Pain is a common problem with dementia patients and prevalence is high. It is estimated that at least 50% of dementia patients experience pain on a regular basis, which is not surprising considering that advanced age is an important risk for dementia as well as pain. The presence and location of pain, although similar, can depend on the subtype of dementia. The three most common areas of pain is musculoskeletal pain, which is the most common in dementia patients, neuropathic pain, and orofacial pain, which is the most common in the elderly population in general. Pain can be associated with neuropsychiatric symptoms such as behaviors in regards to agitation or aggression, the decline of cognitive functioning, reduction in the ability to perform activities of daily living, which inevitably decreases the quality of life significantly. Additionally, the cost of care for dementia residents is threefold the cost of non-dementia residents, with approximately 30% attributed towards the management and care of disruptive behaviors. Research shows that the use of psychoactive medications and the use of restraints to curtail disruptive behaviors often ends in falls, impaired functioning, decreased mobility. Better approach to managing disruptive behaviors would be to control the possible causes, such as pain. Associated behaviors. This would depend on the dementia subtype and the stage of dementia, such as whether the stage is mild to moderate or moderate to severe. Aggressive behaviors and the frequency of agitation are positively associated with severity of pain 50 to 80% of the time. Now, locomotion, such as wandering, which is common in 40 to 60% of dementia patients, is not an associated behavior for pain, as movement can cause more pain. Therefore, wandering can be indicative of the efficacy of pain intervention. On another point, these associated behaviors that are disruptive are a substantial contributor to the stress and burnout of the caregiver and nursing staff. Here is a cartoon that I'm sure that is all too familiar. The caregiver says to herself, Emma keeps insisting she has to go to the bathroom. I take her, and as soon as we return to the bathroom, she wants to go again. If I tell her we've just been there, she frowns and repeats that she has to go. She does this day and night. I am so tired. The short-term memory loss of dementia patients can exude repetitive requests, which in this case can be categorized under the behavioral symptom of agitation in the form of repetitive questioning. Types of dementia. There are many types of dementia. Alzheimer's dementia is the most prevalent at approximately 60 to 80% of all dementias. Second most common is vascular dementia at 20 to 30%. Third is dementia with Lewy bodies and affects approximately 10 to 20% of dementia patients. Other dementias are frontotemporal lobar degeneration, mixed dementia, Parkinson's dementia at approximately 10% of the rate of the Alzheimer's dementia. Then there's Creutzfeldt-Jakob disease, otherwise known as mad cow disease, and normal pressure hydrocephalus, which is a condition of excessive spinal fluid in the brain. Here's a dementia umbrella. Dementia is not a disease in itself. The term dementia is used to describe the collection of symptoms caused by disorders affecting the brain. There are more than 100 different disorders that cause dementia. The four main types that will be covered are Alzheimer's dementia, vascular dementia, dementia with Lewy bodies, and frontal temporal dementia. We will examine the relationship between these different dementia subtypes and behaviors. Alzheimer's dementia behaviors. It is suggested that neuropathological changes such as gray matter atrophy can lead to increased pain tolerance in those with Alzheimer's. Alzheimer's dementia is a progressive disease that has a life expectancy of as little as 4 up to 20 years. It is the sixth leading cause of death in the United States alone. In the early stages, symptoms can be mild memory loss, whereas in the late stages of Alzheimer's, the inability to carry on a conversation or respond to the environment can be affected. Noticeable mood and behavioral changes are observed, and the patient can exhibit delusions, become suspicious, have difficulty walking, swallowing, or speaking. Here's an image of a healthy, normal functioning brain and a brain afflicted with severe Alzheimer's dementia. Not only will this affect behaviors, but imagine the possibility of pain. Although gray matter atrophy may provide some pain tolerance, it will be the behaviors that will be the indication of pain presentation. Vascular dementia behaviors. In vascular dementia, the white brain matter is predominant, which causes greater pain for this subtype than any other dementia. Vascular dementia causes sudden headaches and walking difficulties. The causes of vascular dementia are brain injuries such as a stroke, otherwise known as a CVA or a cerebrovascular accident, which can cause brain bleeds or vessel blockage, leading to lacunar infarctions, which are vessel blockages to the brain's deep structures causing necrosis or death to affected vessels or tissues. Vascular dementia patients will exhibit thinking changes that can be mild to severe depending on the damage, causing confusion, disorientation, and vision loss. Here's an MRI that shows a scan of vascular dementia on the left and healthy brain to the right. In slice 1, you can see the predominant white matter on the left as compared to the healthy brain on the right. In slice 2, it points to the lacunar infarctions on the left. Dementia with Lewy bodies, otherwise known as DLB behaviors. This subtype involves Lewy bodies in the cerebral cortex. These Lewy bodies are clumps of protein, alpha-synuclein, which causes malfunctions in the autonomic nervous system that regulates the functions of your internal organs. Symptoms of this subtype are well-formed visual hallucinations, muscle rigidity, similar to Parkinson's, sleep disturbances, and these patients can act out dreams, which can sometimes be violent in nature. Dementia with Lewy bodies. Here you can see a large pink circle on the right side labeled A. This is a Lewy body. In the center labeled B is some brown pigmentation. This is normal brain pigmentation. To the left labeled C is the cell's nucleus. It's the control center. Frontal temporal lobar dementia, the behaviors. As with Alzheimer's dementia, the frontal temporal dementia has neuropathological changes such as gray matter atrophy, which may lead to increased pain tolerance. There is nerve cell damage in the frontal and temporal lobes. With this subtype, symptoms exhibit primary progressive aphasia, which is the inability to communicate or express language. There are personality, behavioral, and language changes. Muscle and motor skills are also affected. Pain behavior recognition. With pain, the need to recognize the frequency of pain or pain behaviors during the day and its intensity. In regards to agitation as a pain behavior, the patient will exhibit periods of restlessness or repetitive physical movement such as banging on a table. Pain behaviors also exhibit aggression in the form of verbal or physical abuse. You may observe socially inappropriate behaviors such as fondling of self or others, for example. Another observation is resisting care. These are typical pain behaviors and should be recognized and reported. Here is a pain ad. This tool is used for pain assessment in advanced dementia, also known as pain ad, and should be used to observe body language to determine levels of pain. Total scores range from 0 to 10 points. Interpretation used can be 1 to 3 equals mild pain, 4 to 6 equals moderate pain, and 7 to 10 equals severe pain. CNA interventions. Observe pain behaviors and report to the nurse. Aggression pain behaviors. Residents with dementia may become verbally abusive or even physically abusive. This is a positive sign of pain. Socially inappropriate remarks or resisting care are positive signs of pain behaviors. Agitation pain behaviors, exhibition of disruptive vocalizations such as screaming or repetitive questioning are signs of pain, as well as physical aggression. Another agitation pain behavior is psychomotor restlessness or repetitive physical movements, such as repetitive beating on a table. These pain behaviors should be reported to the nurse. Sometimes removing the residents from an area of overstimulation may calm them initially, but the assessment of pain must be addressed. Nurse interventions. There should be open communication between the nurses, CNAs, and other staff members to provide a culture of safety in finding resolution to the pain needs of dementia patients. Assessment of the level of pain should be done. The use of pain ad, Wong-Baker faces, or pain scale, or otherwise known numeric pain scale, should be used appropriately in determining the level of pain of dementia residents at early and late stages of dementia. Non-medication interventions such as repositioning, moving to quieter environment, offer a favorite beverage or food can be used to diffuse an escalating situation. Appropriate pain medication administration should be initiated. Document the pain behaviors and the pain number and tool used is appropriate. In conclusion, the evidence is suggested of behavioral assessment tools in the early and moderate stages of Alzheimer's dementia and subtypes. Cognitive assessment tools additionally are needed to monitor the progression of the disease. In the severe stages of dementia, evidence-based research shows scheduled pain medications to be the most effective for this group due to a lack of sensory and motor responses for accurate assessment. Although there are various combinations of observational behavioral and pain assessments and tools, there is a dire need for a standardized assessment for this frail population of cognitively impaired. Further studies are needed to determine a gold standard for pain management of the Alzheimer's and other subtypes dementia patient. Nursing implications. The implications for practice would need to start with education and training. The education of the clinical manifestations and progressions of pain in patients with dementia is important in the understanding the physiological pathways of this disease and the behavioral and pain assessment tools needed to pinpoint the progression of Alzheimer's dementia and its subtypes. The implementation of adequate assessment tools for behavioral and cognitive functions that should at least include the MDS, which is a minimum data set, CPS, cognitive performance scale, and the DBS, discomfort behavioral scale, for baseline assessment and progression of disease. The assessment tools used to identify the progression of Alzheimer's and subtype dementias should indicate when scheduled pain medication should be implemented. An assessment of pain in the early stages is an indication that there will continue to be pain in the final stages. Thank you. Here are the references. Thank you very much.